Good morning and welcome to the Wilson Center. What a great way to start a Tuesday morning, right? My name is Sarah Barnes and I work with the Maternal Health Initiative here at the Wilson Center. As many of you may know, the Wilson Center is a living memorial to President Woodrow Wilson, who remains the only president to have earned his PhD. We've just begun our 50th anniversary year and are thrilled to be partnering with USAID's flagship maternal and child survival program today to bring you this really important discussion on addressing critical health systems barriers to improve reproductive, maternal, newborn, child, and adolescent health services. And as I mentioned earlier, with almost 400 RSVPs for this event, it is clear it's very important to many of us here. A special welcome and thank you to the incredible group of panelists and moderator today, and to Charlene Reynolds and Holly O'Hara from USAID's flagship MCSP, and Yuval Cohen from MHI for all of your hard work. And without further ado, it is my pleasure to introduce you to our moderator for today, Joan Maurer. Joan Maurer is the head of development, and training at the Broadcasting Board of Governors at Voice of America. Ms. Maurer has extensive experience working with media overseas and in the area of health. And now I turn the event over to you. Welcome.
Thank you, Sarah. I'm going to stand. Good morning, everyone. Thank you for being here, and wow, what a crowd. And there's more in the back there, so you guys are the lucky ones with seats up front. We've got a really exciting panel today. It's actually going to be a two-part series. We're going to have our panelists up here present first. There's plenty of time for questions and answers, and that's really what I prefer because I love to hear your questions from the audience, and so there'll be a lot of time for that. We're going to then have a second panel where they'll have a discussion. Our panelists will have a discussion among themselves, along with questions from you guys. Just a couple of housekeeping notes. We do have, we had up here, the hashtags if you want to tweet. Will you put it up, Sarah? Okay. Okay, the next slide will have the hashtag so you guys can tweet. We've already gotten questions from Tanzania, so we're not going to be at a loss for discussion points. Our panelists have prepared PowerPoints, and those will be available on the Wilson Center's website after the event, because I know a lot of you want to take their PowerPoints home. This event is really, it's amazing how many people it's drawn and the level of our panelists who are all experts in the field. I have to say, when I first got the list, there were so many acronyms that I was kind of like, oh my God, what am I going to do here? But I think we're going to get into some, so it's not going to be all acronyms, and many of you know the subject very well in any case. Just to put it in perspective, maternal and child health, since 1990, number of children's lives saved has been 100 million through USAID's efforts. USAID and other governmental officials and governments have played a large role, but the U.S. government itself has spent about $15 billion on this subject, on this issue since 2008. So there's a lot of money going on into it. There's been a lot of success, but as you'll hear moving forward, there's a lot of room for improvement and a lot of places that we could do better in saving maternal and child health. So without that, I'm going to introduce our panelists, but I'm not going to give you their full bios, just because I think you have information on them, and it just eats up our time. So let's start with our first speaker to my left, Grace Chi. Grace is put my glasses on here. She is the Health Systems and Equity Team Leader at USAID's MCSP Maternal and Child Health Survival Program. Grace, I'm going to let you have the floor.
Thank you. Good morning, everyone. It's great to see such a packed room. Let me just make sure I can work my slides. So I know many of you here today are passionate about improving the lives of mothers and children. And I know many of you are also passionate about strengthening health systems in order to improve access, coverage, quality, and efficiency across all health services in order to improve health. I'm here today to convince you, and I think my fellow panelists will support me in this goal, that we cannot achieve our goals for ending maternal and child deaths without addressing critical health system barriers around the world. and that a marriage, or at least a partnership between RMNCH and HSS is what we need. So what do health systems look like in the countries where we work? Well, 83 countries do not meet the basic threshold of 23 health workers per 10,000 population. 3.5 billion people, or about half the world's population, do not have full coverage of essential health services. Within the countries, there are stark disparities in coverage. So in low and middle income countries where we work, only 17% of people in the poorest quintile have received a set of at least 6 out of 7 essential maternal child health services. By contrast, people in the wealthiest quintile, 74% of them receive the same package of services. So there are great inequities. So what do we know about maternal and child health? Well, we know the most prevalent causes of death, both for pregnant women and for children and babies. I won't go into these in detail. Many of you are very familiar with them. But I think even more importantly, we know what the essential services are that can help address some of these conditions. So for child health, I show here, this table shows 13 high-impact essential services for child health. We don't need to read them. I won't go through them in detail, but I want to make 2 points here. You'll see that these services are delivered across all levels of the health system, from the community or health post level to the primary health care center to the first level or referral hospital level. 6 of these are shaded in red, or this bottom gray part, and those denote ones that require urgent care. 2 others are shaded in blue, and those require ongoing care. So of these 13 services, even a simple one like number 3, immunization, is not so simple. It requires 5 interactions between a baby and a health worker in the first year of life. So while we know what the essential services are, it's not so simple to deliver them. And for maternal and newborn health, it gets even more complicated. You'll see here a set of 35 essential services. You'll see that 24 of them are shaded in red, meaning they require urgent or emergency care. It requires emergency transfer to a higher level of care at times. Again, they're delivered across all levels of the health system. And including at community level. You'll see number 1 is birth preparedness and emergency planning for labor and delivery. We know that that's a life-saving intervention. It's not even really a health service, but it's a part of service delivery and making sure, a key part of how we save mothers and children. So these services are known to be effective, but they don't deliver themselves. Many different people need to be doing exactly what they're supposed to all the time to ensure positive outcomes all the time. So while we focus on the services and service delivery when we talk about saving lives, ensuring that everything works right every single time goes well beyond service delivery. And when I say that, I mean we need to engage all parts of the health system. So what does that mean? This diagram shows all the different parts of the health system with a centerpiece around service delivery. So again, and within service delivery, we want to recognize patients and communities and their role as users and their acceptance of health services as a key part of effective service delivery. But we also have to recognize the rest of the health system, and again, the role that communities and patients play in the rest of the health system. So these services, high quality and coverage of these essential services, cannot be achieved without trained and motivated health workers who have the medicines and equipment and technology that they need to deliver these services. And that relies on strong management and leadership, managers and leaders who are able to advocate for sufficient funding for the equipment and health workers that are needed. And those decisions are based on reliable data about health and health conditions. So all elements of the health system need to converge in order to deliver quality services. I'm not sure whether that animation properly showed convergence, but that was the goal. And I think beyond that, we need to go even a step further. Beyond service delivery and even beyond engaging all parts of the health system, we need to address the fundamental operations of the system to create sustainable change. And I want to use this cube to help describe that. So you'll see here on one dimension of the cube, we see the WHO building blocks. And that's a great framework for us to think about what are the functions of the health system that need to be working. I matrix that against various health programs that are implemented at country level. So certainly to implement RMNCAH, we need to have the physical facilities that are well-equipped, that are accessible. We need to have trained health workers, medicines, et cetera. We can't even begin to deliver services without that. But sometimes when we face stumbling blocks, we turn to quick fixes. So what might that be? So for MCH, if we find that there are critical medicines that are not in the facilities that we need, what might we do? We might procure those medicines and figure out a way to get them to the facilities where we need them. But that's not a permanent fix. In order to create a more permanent systemic fix, we need to address what I call the performance drivers within the system. So, for example, using the example of medicines again, although we think the bottleneck is around medicines, what are some of the systemic factors that cause the lack of medicines? Well, it could be that resources were not allocated properly to have the medicines that we need where we need them. It may be that the supply chain was not functioning well, that things didn't get delivered on time. It may be that health facilities don't have any way in order to get medicines once they're stocked out. They're just sitting there waiting for medicines to come to them. Also, it may be that our data is not reliable on what types of health conditions are prevalent in this area and what medicines are needed. And then lastly, we need to have mechanisms to hold people accountable for performance. So I think those are the types of interventions that create systemic permanent change to improve the health system. So why focus on health systems? I want to give a couple other reasons. First is the scope of the issues. I think they are too large for one program or one partner. We can't achieve and sustain the goals for RMNCH. TB programs can't achieve their goals. HIV programs can't achieve and sustain their goals without addressing the underlying health system issues that constrain delivery across all health services. Second and thirdly, around fragmentation and inefficiency. In the low resource environments where we work, we can't create parallel systems and approaches. Rather than each program, each health area trying to figure out how to get medicines where they need to go, how to train their health workers to deliver their health services, we need to find a more efficient way to improve the supply chain for all, to improve training policies for all. And then lastly, sustainability. Only by changing how the system fundamentally operates, these performance drivers, can we have sustainable improvement. And we can only do that working hand in hand with national and subnational leaders. Only they can really change the system from within. And then lastly, I want to remind us of USAID's Acting on the Call report from last year, which estimates that we can save 5.6 million children and 200,000 women by building strong and resilient health systems. So beyond our meeting today, I do believe this is a special moment in terms of recognizing the importance of health systems for improving RMNCAH. And I want to offer a couple, examples of why I think that. So first, the Global Fund strategy, the current strategy, has a core objective of building resilient and sustainable health systems. Including sub-objectives, which say supporting RMNCAH and platforms for integrated service delivery, and leveraging critical investments for HRH. And when they point to HRH, they don't just mean training health workers. They're looking to find ways to improve workforce planning, improve working conditions, reward systems, policies on training, et cetera. One of the key findings from the disease control priorities work was that weaknesses in RMNCH delivery platforms, including limited access to care, poor quality services, and shortages of health workers or drugs, are a major barrier to improvement of RMNCH outcomes. And then lastly, the Lancet's Maternal Health Series concluded that partners must invest in strengthening the entire health system, including data and surveillance systems, facility capability, emergency services, and a skilled workforce in order to respond to the threats of maternal and newborn health. So I hope this evidence and the presentations to come will leave you fully convinced and energized to work to resolve these persistent health system challenges in order to improve the lives of the health of women and children. Thank you.
Grace, thank you very much for a really nice overview, putting things in perspective. Our next presenter is Dr. Miriam Clayson. She's with the Global Financing Facility at the World Bank. since the financing facility deals with money, a topic that underscores a lot of this. She'll talk a little bit about how the financing system, the GFF is working, how it's funded, and what it's achieving.
Thank you so much. Like the previous panelist, I'm also amazed that we are here actually talking about health systems and health system strengthening. Whoever thought that that would be such an attractive topic? But that, I think, really shows how far we have come as a community in global health. Grace has summarized so well that the fact that we know what to do, we know how to do it. So how do we now put the financing behind it? And the case I like to make is that to put the financing behind health system strengthening, getting the services for mothers and newborn and for women, children, and adolescents to the front line needs a new way of thinking about financing. We can't continue to do it sort of disease or condition by condition or program by program or intervention by intervention. We have to rethink how we finance for development. Otherwise, we are not going to build those strong, resilient systems that can deliver for women and children and adolescents. And it's good to really sobering, I think, for us to think about why we are here. We're really here to eliminate preventable deaths and improve the health and well-being of women, children, and adolescents. And we are fortunate in the RMNCAH and N community that we actually have countries signed up to achieve targets. We don't have to have a debate over the next few years. What's the target we need to achieve? We know what the targets are, thanks to the work that many of you in this room made. We know the maternal mortality, under 5 newborn targets. There are targets now for SRHR services, nutrition, and universal health coverage is something countries are thinking about. But to reach this, and if we reach this, we know that we can save up to 38 million deaths by 2030. So how do we get there? This is why the Global Financing Facility was created, in fact, with a lot of support from USAID and other partners who thought, what does it take to finance at scale and sustainably? Where are we today? This is from this month's, the new countdown to 2030. Where we are today is the recognition that I think many of you have, which is that we have to double the rate of reduction of maternal, newborn, and stillbirth deaths to get to our targets. So we are really talking about doing more difficult things to get to the neglected communities, neglected interventions, and neglected age groups. So the approach that I'm going to present to you now after 16, we have 16 operations, we just added 10 more, is really what the GFF is trying to do to make this happen, to translate intention into operationalization. So starting though with the impetus for GFF, this is an interesting pie chart. We talk a lot about ODA and how we need to increase overseas development assistance, right? But when you look at the money that's out there, ODA is just a small sliver of what's available in terms of foreign direct investments, remittances, and most importantly, domestic resources. So how can we use smartly our ODA to also leverage those other sources of finance for women, children, and adolescents? And if you look at the right-hand side, we know that we need 33 billion. Over the past few years leading up to the 2015, development assistance was around 36 to 38 billion. That's, if we would take that, that's almost all of that money for this cause. So clearly we have to find ways of mobilizing the money for mothers and newborn, for women, children, and adolescents through other means than just the ODA share. That's why we need a new development finance model. Here, we're trying to capture this. If you look at the left-hand side, that's the 33 billion gap, right, in 2015. If you move all the way to the right, that's closing the gap by 2030. And how do we get there? At the top, you see an arrow going down. That's just reducing inefficiencies, getting countries to spend the budget they already have for the interventions we just heard about. But it's also to make sure that we that we do indeed invest in the highest impact interventions that Grace talked about. The bottom line, see a curve going up. Some of this is just projections of economic growth and what that can translate in terms of domestic resources. But then you see how we try to boost that. We leverage, we proactively mobilize domestic resources. We link to IDA, IBRD, World Bank financing. And by the way, right now, the GFF is linking $1 spent in the trust fund to almost $7 of concessional financing. So the combination of inefficiencies, domestic resource allocation, aligning bilateral donors, crowding in private sector money, which is the remaining 7 billion gap, is where we hope to get from really innovative, cross-cutting, frontier thinking around how to mobilize private capital. That's how we're going to close that gap over time. So this is the reality, though. This is from a presentation done by the Minister of Health of DRC. This is what the world looks like for most countries today, right? They have all those multilateral agencies, they have steering committees, they have humanitarian NGOs. If you're a fragile country like DRC, you have all the bilaterals and various public institutions. So if we are going to really put the money behind high-impact interventions and steer those in the direction so we eliminate preventable maternal newborn deaths, clearly we have to put the country here for the first time, for real, in the driver's seat, to bring together these partners, align them around one strong investment case. And we have a very good investment case to make for the areas of human capital that we are talking about here today. So this is what DRC and other countries are doing to change the way we are doing financing for health and nutrition. First of all, identify those priority investments that are really going to achieve your RMNCAH and end goals. Have a strong investment case that you can take to your Minister of Finance and say, yes, that's where I'm going to put my budget. Identify those priority health finance reforms. Oh, I have only got 2 minutes. I better rush then. And once you have your investment case, then you leverage these the domestic resources that you link to concessional financing, external financing, and private sector money, and the cycle starts. So this is where countries are moving in this process. When we say that we support health systems, it's because we have an outcome-driven approach, right? You look at those outcomes we care about. There are specific interventions. There are integrated community platforms. There are multi-sector contributions. There are the health system specifics, right, on health supplies, human resources, and the health financing reform. Here's the example I wanted to give. This is Mozambique, okay? Mozambique has huge challenges. So what have they done? They have developed an investment case and identified their biggest health systems challenges. That services aren't available, period. Human resource shortages, lack of those community platforms that we can integrate our services on, low quality of care, and low and inequitable government spending. What are they going to do to challenge this with all partners aligned, including USAID? It's to improve availability of emergency obstetric neonatal care, water supply and sanitation in facilities, right? SRHR services in schools, because teenage pregnancies is huge. More health professionals on the front line that are equipped and incentivize good practices in the front line, and then protect and improve the share of health in the government's own spending. So you aren't expecting Mozambique to suddenly increase its domestic resources for health, but what they can do is start to work on a plan. They can protect the budget they have, and they can start to work towards increasing it. And here, given the time, I won't go through, but what's really interesting and cool is how you can link these indicators, these systems indicators, with disbursement of financing, right? So that you disperse against outputs, against health finance indicators, service delivery, quality of care indicators, and they're very specific. So this is how you get then the system to link program interventions with actually the financing. How, for example, is money going into underserved areas? Are domestic resources increasing over total government resources? Are there more technical health personnel assigned to the primary health care level? If you have these kinds of indicators and you link to that, that's how you get the government to actually stay focused on results, move forward, and then bringing all the partners along. This steers investments to the front line, because that's where you have the neglected areas, populations, and interventions. So Mozambique is steering its investments to those parts of the country that are underserved. Liberia, to those provinces that were worst hit by Ebola and were still neglected and where they need to build the resilient systems. Guinea is doing the same thing. And in Nigeria, we are working in the northeast part, in the Boko Haram areas, where purchasing for performance is actually increasing the use of mothers and newborn services in the population. So a little sample of what we try to do, and happy to expand more in the question and answer session. Thank you.
Thank you, Mariam. I think you have the slide of the day with the DRC slide with all the different partners. Let's get these people working together. On that note, Lee Pine-Mercier is from the Gates Foundation. One of the goals of this event today is to talk about public-private partnerships and to see how we can work more effectively between government and the private sector. Over to you.
Okay, thank you all for coming out today, and good morning, happy National Pancake Day. If you were at the wrong event, actually you can head up 14th Avenue. There is an International House of Pancakes with free pancakes all day. I'm here to make this presentation on behalf of a very talented team in working both out of Seattle and out of Nigeria. So over the last 25 years, coverage of health interventions in Nigeria has really been stagnant, and this makes Nigeria a real outlier in the African continent. In most countries, coverage of MNCH interventions has increased over time. And in addition, health outcomes in Nigeria are very poor. As was mentioned before by Grace, there's significant variations between rich and poor, and outcomes are generally worse in the northern part of the country. And despite a fairly large number of health facilities and health workers in the region, certainly compared to peers in the Africa region, there are very important bottlenecks in the areas of skills, supplies, equipment, and financing. And a root cause here is the weak PHC system, but this in turn is driven by weak governance. And we need to address this as a global community if we'd like to achieve sustainable change in Nigeria. Now, most externally funded efforts, including the work that we've supported and continue to support, are vertical. They've had a lot of challenges in achieving goals, and virtually none have been able to sustain their gains in the long term. This slide actually summarizes some of the changes in the approach that we've taken over about the last decade. Many of our technical teams decided to work in Nigeria either because of the burden of disease or in pursuit of achieving global goals, such as Family Planning 2020 or polio eradication. And our early focus was on service delivery of particular products and services, often through vertical channels or through campaigns. And early family planning investments, such as NURI, which you see here on the left, were an example of this approach. And a shift towards more systems thinking appeared in 2014 with work on data and performance management. And our evolving approach really complements service delivery investments with work on sustainability and system strengthening, much of which is defined through memoranda of understanding that we develop. So this slide will be familiar to, I hope, all of you with the WHO building blocks. And our early investments really focused on service delivery in that bottom building block. But the lessons from our focus on routine immunization really emphasized that we needed to enhance our work in the other building blocks. In the interest of time today, I'm just going to talk about two that I think are particularly important in Nigeria. They are on governance and financing. And while we also support work in the other building blocks, I won't talk about that today. So here on the left side of this slide, you will see a memorandum of understanding that we signed last year with the government of Niger State. And we've established MOUs with governments in 8 states, and they clarify the roles and expectations on both sides. These allow us to become co-investors in the state health system and to further develop our partnerships with the government. And we've really learned that it's essential to also engage with state governors as part of this process. They're politicians, but they have a high degree of control over both budgets and execution in their states. And we also actually have to follow up on a regular basis and ensure communication with them to monitor progress, usually on a semi-annual basis. The MOUs allow us to align our grantees' work and that of other development partners towards a common set of goals. And in many ways, this is a similar approach to what Mariam had talked about in the investment cases that the GFF is developing. So in addition, there's many donor and NGO partners in Nigeria, similar to the DRC, and this has led to significant fragmentation and duplication of effort. For example, Kaduna State has 31 different technical working groups. They often have overlapping responsibilities. Many are driven by partners. We're supporting states to harmonize technical working groups and to develop a single work plan that includes all activities, both by development partners and by state agencies, and that's aligned with a long-term strategy. So it's also been important to clarify the internal structures within state governments. Before Nigeria's primary healthcare under one roof policy, there was a lack of clarity on roles and accountability. Multiple agencies worked inside each health facility, and no single agency was accountable for results. As a partner, we've supported states to implement this policy, and as you can see, there's increasing clarity in org charts from 2010, and this is 2010 where you can see that that PHC facility has many bosses, through 2014, where there's actually more alignment between different agencies, and 2017. And so we've provided assistance to the state to help organize its agencies. Also, in many of the states where we work, we've established joint basket funds, and these include money from the Gates Foundation, but also from the state government and other collaborating donors. The funds are managed by the state through state systems with accountability mechanisms, and they serve to really crowd in state resources that might otherwise be diverted or go to other purposes. And the total amount of the basket funds is determined by the state, and the state commits to fully funding the activities at the end of the MOU. This means the size of each of these programs is relatively modest, but we believe they have a higher likelihood of sustainability and certainly of ownership. These programs are implemented by state staff using state systems rather than through partners, although we do rely on partners for technical assistance. This image here is an example of funding allocations between partners in Bauchi State under the MOU. As you can see, the government share increases over time, and we partner with others like USAID for technical assistance. And the basket funds work hand in hand in financing with our governance approach, with funding released based on key milestones, similar to the DLIs that Mariam was talking about. For example, in 2017, Kano fully funded its immunization system after years of external support. So you can see here in Priority 1, this was on a recent review of MOU progress. They did fully fund their MNCH work. And this allowed us to expand our partnership beyond immunization into other areas of MNCH in 2018. I'm not going to go into detail. This is a complicated slide, but I think it just provides an overview of how different state engagement models are tailored to different state health systems and epidemiological considerations. We're also working to strengthen the capacity of the federal government to disseminate and diffuse lessons from our focus states to other parts of the country. And I should add that we are strengthening and empowering our country office in Abuja to ensure that they have a deep understanding of the health system, that they're empowered to make decisions, and that we're also developing a country strategy to move beyond vertical approaches that are defined in Seattle. Thank you very much.
Thank you, Lee. Wow, are you going to interpret some of those acronyms for us up there?
We can.
Yeah, no, that was fascinating, and I think really tied into what Mariam said about the needs to support governments, local, state, and federal. We're going to move now to Dr. Berhanu. He told me I didn't have to pronounce his last name, right, Berhanu? We're going to talk about Ethiopia. I'm sorry, you're from Ethiopia. We're going to talk about Liberia and get down to a more granular level here. Thank you.
Okay, thank you very much. So I'm representing the two maternal and child survival programs from Liberia. So I'm representing the teams here, the work that I have done. So we have gone through the basics of health system strengthening, and then we are going to share with you what is the experience in Liberia. So as you know, Liberia is a country with a population of 4.2 million, with 15 counties. Civil war has affected the country between 1989 to 2003, which has caused the deaths of 150,000 people has died as a result of civil war, and 850,000 has been displaced. And in 2014, Ebola has came into picture, and then it has also affected the health system as well as other infrastructures in Liberia. So Liberia has a very big...
Do you have your clicker?
Yeah. So Liberia has high teenage pregnancy, which is 31%. So showing us mortality is very high. So I'm talking two programs in Liberia. One is the restoration of health services. This project has started in September 1, 2015, and it's going to end by June 30, 2018. It is a quick response following Ebola. It has been aligned with the essential package of health services. It's so to address quick fixes to the health system. Most of the facilities were not open. Only 57% of the facilities were open. Low utilization rate because the citizens has lost confidence as a result of Ebola. So the health workers has been affected as a result of Ebola as well. So this project works in 3 counties, Nimba, Lofa, and Grand Bassa, in 77 facilities, and that population accounts to 900,000, which is almost 20% of the Liberian population. It has 2 objectives. One is improvement of prevention of infection prevention and control at facilities, and second one is provision of quality maternal, newborn, and child services. So the second project is that focuses on human resource for health. That has started a bit late. It is almost 2 years. It is a 2 years project. It focuses on pre-service education. The program is aligned with a national strategy which says fit for purpose health workforce. So Liberia is not an exemption to all the countries. Liberia has a shortage of doctors, nurses, midwives. It is not meeting any of the global standards, which is 23 per 10,000 population. So midwives, lab technicians are very scarce. So this project has to focus on 2 priority areas which are very key for the maternal, newborn, and child services. So it operates in 4 counties, Monserrado, Lofa, Bong, and Granjida. It covers all the midwifery schools. It covers all the lab schools in Liberia. So it is 100% coverage. So it addresses the nation's requirement. It has 2 objectives, to improve the quality of instruction as well as strengthen the learning environment. So after Ebola, indicators were very poor. Only 57% of the facilities were open as a result of shortage of staffs, medical equipment, no infrastructure at all. Pentastry coverage has went down to 43%. Clients were not utilizing the services. They lost confidence to come to the facility. Health facility delivery has dropped from 52 to 38%. So Ebola has also affected the health workforce. Nearly 400 healthcare workers were affected by Ebola. 175 has died as a result of that. So Ebola has affected the population as well as the health workforce. When it comes to human resource for health, 59 health facilities were assessed. So the 2 health workforce, which are midwives and lab technicians, were very low in Liberia. So the project has to focus on 2 programs to make most out of youth. So when it comes to technical approach in terms of the restoration of health services, it is an ongoing support, which is a multi-pronged one. It conducts regular assessment of facilities in terms of infrastructure, supply chain, human resource for health, and then the quality of care that's provided at each facility, and then provide a need-based support in terms of supply chain, human resource for health, equipments, and then conduct some renovation works, and then sometimes you would be forced to pay salaries for staffs as well. And through this project, 132 professional and non-professional staffs were put on salary by the project. And then this has been coordinated on monthly and quarterly regular coordination meetings, which aligns to avoid duplication of effort by partners. The success for this project is it is need-based support. It is a multi-pronged approach. It is not only on human resource, but it also covers infrastructure upgrade, supply chain, health workforce development, and competence, and the collaboration has worked very well. The human resource for health has, I'm not going to go through the details of how the strategy and technical approach, but a quick fix with a lasting effect for the project. Some of examples of the outcomes through both projects showed that the quality of care has improved through the restoration of health services. It was from baseline, midline, and endline has shown in almost all technical areas that covers antenatal care, labor and delivery, child health, immunization. When it comes to human resource for health, it was assessed in 5 institutions, and most has shown improvement within a 2 years investment. More children are using services from facilities, so confidence has been restored. So more children are treated for pneumonia, and more children are treated for diarrhea using a new protocol that has zinc within it as well. When it comes to human resource for health, most schools are well equipped. They implemented the OSCE, which is objectively structured clinical examination, and more are competent. Midwives and lab technicians are performing very well. Both projects are always assuming that it has to be sustained and continued. One is the big success is throughout all our implementation strategies, we have engaged the counties, districts, so that we have transferred the skill so they can implement the project. And second one is the investments that we did, such as construction works within the facilities, as well as medical and non-medical equipment that we provide can be used even after the close of the project. The third one is the health workforce capacity has been built at county, district, and national level. So they do have the soft skill to strengthen the health system, even after the close of the project. In terms of human resource for health, almost they complement. Engaging, involving all actors together has helped to ensure sustainability. Enhancing capacity of the faculty and preceptors is a big investment, and the skill lab establishment has also helped us. So I've trashed on some of the slides, so I hope you will raise it as a question and answer.
Thank you, Doctor.
So the last thing that I would like to say is always quick investments should always be complemented with, to restore confidence in health system, has to be complemented with a long-lasting investment like infrastructure as well as human resource for health upgrades. Thank you very much.
We're on a forced march here, so we want to make sure we get through everything. Dr. Stephen Mutwewa is the MCSP head in Rwanda, and he's going to give us some insights from that country.
Thank you very much. I'm very excited to share what we are doing in Rwanda. So for a moment, welcome to Rwanda. We call it land of 1,000 hills, but the hills are much more than 1,000. So you need to visit and see. And Rwanda is one of the countries that actually achieved all the health MDGs. And we have seen a reduction of maternal deaths from 2005 to 2015 by 72%. And child deaths by 67%. So I'm going to be sharing with you a little bit of what we are doing, and probably you see the reasons why Rwanda has been able to make that kind of progress. Right, so just to talk about how we are strengthening the system there, I think the main thing is that we had to make sure that what we are doing is anchored in the policy and the guidelines, so that it's something that is nationwide, it's something that is being implemented with one focus. And then we also had to make sure that people are using data routinely. They have a mechanism to look at their data, even at facility level, and make decisions that are based on their data. And then my colleagues have talked about empowered and skilled providers. So we had to make sure that these providers have the skills to provide RMNCAH services, and not just the conventional ways of building the capacity. We had to look for innovative ways to build the capacity. I'll be talking about that in a moment. And then make sure that the government has capacity to scale up high-impact intervention, because we know as much as these interventions, they work, if they don't reach everyone that needs to be reached, then we are not going to make a difference. And then we had to begin with the end in mind in terms of making sure that we are going to leave capacity within the country. So we are working with the professional associations, we are working with the Association of OBGYNs, the pediatricians and the midwives to go out and mentor the different facilities. Then we have to make sure that quality is a key thing in providing these services. What I did mention is that in Rwanda, 91% of the women are delivering in facilities. That means these are huge numbers. If you don't give quality services, then you are going to erode the confidence of the clients. So I want to talk a little bit about the innovative way we used to make sure we build capacity of providers, their skills. We call it the low-dose, high-frequency approach. Basically, we know the conventional way of training was kind of falling in disfavor with most stakeholders because it was expensive, and then it was drawing providers away from their facilities, creating an artificial shortage. So we had to find a way of approaching that. And so what we do is that these providers are trained by mentors within their working environment, where the mentors who have been trained at the hospital, they can go to the health center and work with the nurse there within our own environment, so that you are also troubleshooting the issues that they face when they are providing these services. And this is just a graphical presentation of how we went about it. We actually realized that this was able to give us much more numbers that were trained within a short period. We spent most of the first quarter and the second quarter doing a little of the conventional training to make sure we have a critical mass that can go out and do the mentorship. And then the low dose started, and you can see a burst in terms of the numbers that were being trained using low dose, high frequency. And these are the different technical areas. We were addressing all of them. And then in terms of the outcomes, we have got, we use the DHIS. I assume most of us know this is the national HMIS system to make sure that hospitals have dashboards. And here they are putting key indicators that will be monitoring for each of the technical areas. And then in terms of scale-up, we introduced postpartum family planning. And this one we did phase-wise. We started with 4 districts. Then we went to 10 districts. And now the government has actually been asking us to go and train beyond the MCSP districts. And then, so we have the trainers and the mentors. In each hospital, you have like 5 of them, and then they go out to the health centers once every month, and they are working with the mentees there. And this mentorship, so it's kind of a different level. So we have the specialists in the associations who are going to the hospitals to work with the GPs. And then we have the mentors at the district hospitals who are going to the health center primary level, and they are working with the nurses there. And then we have nurses who are moving from the health center. They are working with the community volunteers at the community level, doing mentorship. Then I talked about quality improvement. We made sure that each of the facilities, they have quality improvement teams, and they are looking at their performance and coming up with action points to improve the quality of their services. We have also supported national policies. I mentioned we are finalizing the national strategy for RMNCAH and the family planning and adolescent sexual reproductive health. And this is just a slide to show you an example for postpartum family planning when we did the mentorship and they were providing the services. You can see over the quarters, immediately after the first 2 quarters, you can see the numbers just shot up. And the government is very excited with these achievements. They have asked us to support the other districts and make sure each one of those facilities are providing PPFP. And then in terms of the dashboards I talked about, so this is what each facility is able to do, to have a dashboard concerning each of the technical areas they are working on. This is just an example of essential newborn care. And the next one is on family planning. But basically, they are able to see how many providers in this facility are trained, and how is the commodity looking like, and what are their key indicators looking like. And they can know what they need to increase and balance. And what we have done is, after we developed these dashboards with them, now it has been incorporated in the national HMIS system. So the DHIS too, they can go there and look at the dashboard for their own facility. In terms of enabling environment, which has really meant us to make this progress, I really have to reiterate that the government is very strong in terms of leadership. When they see the evidence and what works, they will make sure that this is rolled out in the whole country. They will make sure their policies, their guidelines, and the training goes out. So one of the things they are very excited about is the low dose, high frequency, and the mentorship, because then this is a very cost-effective way of building capacity. And like I mentioned, Rwanda, achieved all the MDGs and now has domesticated all the SDGs in country. And then we have a mission that is really willing and committed to align itself to the national strategies and priorities, and that makes the work much easier. And then we also work very closely with the mission in terms of guidance and determining what we need to do, because again, in Rwanda, you have to be very responsive to the issues that are coming up. And if you are not moving in tandem with the donor, then it can become quite a challenge. And then Rwanda is quite ambitious. Actually, I need to update this bullet since I put it, because Rwanda has Vision 2050 to be a high-income country. So by 2030, we want to be a middle-income country. By 2050, to be a high-income country. And we have the strategies set, and every sector has to align to that vision. It's just excellent. So in terms of legacy, what are we going to be living? We believe that this mentorship approach, because it's being done by the hospital facilities, we are going to have these mentors doing it continuously and leave skills with the providers. And then they have the tools, they have the means and the capacity to measure their progress and be able to adjust appropriately. And they are now routinely looking at their data at the lowest level. Even at community level, they are able to look at the end of the month, how are the indicators looking like? And the capacity to scale up. I've just mentioned last month we had the workshop where the 10 districts came and presented to the rest of the 30 districts in the country on how they did PPFC and helping babies breathe. And the government now decided to roll that to the rest of the country. Thank you.
Thank you. It's great to hear some positive news and to hear what a country can do like Rwanda. Thank you, Stephen. I thought the innovative training and the use of data is particularly relevant to this discussion. We're going to take questions now. You can stand up. I understand there are microphones, so please get your questions ready immediately. So while you're thinking about them, I'm going to ask the first question, which isn't actually my question. It came from a reporter in Tanzania who emailed it to the Woodrow Wilson Center, but it's a subject dear to my heart, and I'm going to address Miriam, which is the role of media and news and information in tackling some of these issues. And does the GFF and do other organizations put media into their strategic plans?
It's really a great question because we focus a lot on supply throughout all of our presentations here, and there is a demand side to that too. And there is an accountability arm. When we talk about governments in countries in the lead, it's governments and civil society. So clearly both civil society at large, but in particular media has a key role to play in many ways, not just in information and so on, but actually in terms of accountability for the results that we claim. So I think that was was a great question from the colleague in Tanzania. In fact, we do recognize the role of media in Tanzania. So the Minister of Health actually had an op-ed not long ago explaining what they're trying to do in improving performance at all levels, from community, district to national, but in particular at community, facility, and district level. But that's one shot. We should have a much more systematic and strategic use of media. So that's a great question, and I think we can do much better with that. Just look here. It's not just us getting together here, but it's the whole using social media wisely and strategic. That's part of this effort, and I think we can do better among those of us global entities to use media strategically.
Great. Could I take a question from the room? Anybody got a question? Please identify yourself and ask your question.
I'm Vinita Gupta, and I'm so glad to hear Dr. Stephen talking about professional associations' engagement in reaching some of the improvements in Rwanda. And I would really like to hear some of your experiences, any panelist, what barriers or what hurdles they face in engaging professional associations, and why they think that it's really important for sustainable RMNCAH outcomes.
Anyone want to take that from the field? Stephen or Dr. Berhanu, how do they engage professional associations in Liberia?
So thank you very much. So one of the projects which is working on human resource for health is working particularly with professional associations. So we work collaboratively with professional associations in terms of coming up with standards, coming up with accreditation of the curriculum, going through the standard curriculum, is it going with the global standards? One of the issues that working with professional associations is they don't have enough resources and budget to run the professional associations. It is, professional associations are usually run by contributions from each members, and members are low paid in developing countries, and then they may not have enough budget to provide technical support to the health system. Otherwise, they do have the technical competency to provide all the support that's needed for health system strengthening.
Thank you. We have a whole room out there which didn't get to come into this room. So they've sent some questions in, and I'd like to start just with one for Grace. One of our questioners wants to know, what do you understand by evidence-based? Can you please define that?
Well, I mean, there is a body of evidence related to what health system strengthening interventions work. For example, in the call to action from last year, I think there were identified 29 evidence-based interventions, and this was developed with a thorough vetting from a panel of experts and from other USAID projects. And they include interventions along all areas of the health system, including ways to improve service delivery, ways to improve health worker training and motivation, financing mechanisms, et cetera.
So there is a list, and we can find that online somewhere.
Yes,
Great.
Acting on the Call 2017.
Okay, good. Let's take one from the floor. How about over here, right here in the front? And I'll go to the back.
Hi, thank you. My name is Danielle Porfida with 1000 Days. This question is for Dr. Birnu and Dr. Stephen. So I think in both of your presentations, you identified the need to scale up high-impact interventions. At country level, what is the process of identifying which interventions are high impact, deserve scale up, and receive that level of priority? Thank you.
Go ahead, Dr. Stephen.
Yeah, thank you very much. That is a great question. I think for Rwanda, we don't work in isolation because there are international standards and there are international guidelines. So one of the role actually MCSP has been doing, being a global program, is to be able to contextualize international standards, looking at the evidence at global level, and then how can it be contextualized. So we go through that process of looking what works, what doesn't work, and then in terms of Rwanda, how can it work in Rwanda? And so we have technical working groups that look at specific technical areas, and from there, once like a policy has been drafted, then it has to go through the process until it reaches the health sector working group, where they are able to validate it, and then now it's decided this is what the country wants to roll out.
Okay, I'm going to take a question from the overflow room. This is from Naoka Kazuki. She's with the International Rescue Committee, and I'm going to address this to Lee. She wants to know how do you adapt when you're working in a country which has little legitimacy, little government capacity, and little legitimacy, and has conflict, like Boko Haram.
Thank you very much. I think one of the biggest challenges we have in health system strengthening is identifying the most effective ways to engage in settings with weak governance, because there needs to be the most effective environment for us to intervene is where there's a real health system steward and where that is the government. And so what I think we've been able to do is, due to a complex federal system in Nigeria specifically, is identify which states and which levers and which individuals are important for us to leverage and work with that can facilitate change. Because I think if you look at a large picture of a very complex state and try and fix everything, it becomes overwhelming. And I think it was people who were very experienced who were able to identify those points of leverage.
Okay, so getting down into the local level almost and knowing people. Let's take a question here from the man right here, please. Yes, thank you.
Thanks. Kami Arkajavi, Management Sciences for Health, MSH. Thank you for calling on me now, because this is almost a follow-up to the question that was just asked, and it's mostly for Lee, but other panelists, please also come in. So Lee, you said that in working with the state governments, you were sort of helping them organize their agencies and so on. I'm just wondering, political commitment being so important to all of this, how do you get them to work together to sort of improve their commitment to all of this? Thank you.
Sure. And how to get the states to work together?
How to get people in the agencies.
Oh yeah. I think there is, and so yes, there are being really thoughtful about what individuals' incentives are in the entire system for their actions. And so I think when we've identified, and this was one of the important parts about that organizational chart, and primary health care under one roof, is to ensure that individuals were reporting into a higher order node, so that differences could be resolved at that level. And so I think that was the most important approach that we were able to take to resolve that when there were competing priorities internally. And so certain governments are organized. A lot of times the donor community is not organized. And I think on both sides we can do a better job of thinking about the incentives and then trying to align them. But it's hard, you know.
Let's go to the back. The lady right there. Yeah, right here.
Hi, Jill Gay, Works Association. Would you address how you're addressing corruption within government systems?
Do you want to take that, Miriam?
She gives all the hard questions to me. Certainly, I think that's a great question, because so many of my panelists have here talked about confidence, used the word confidence. So how do we build confidence in systems so that countries and bilaterals and foundations and private sector are actually willing and able to pull money together towards a government-led effort? So I think your point about how do you tackle corruption up front is great, and Mozambique is a very good example of that. What turned things around there was a change in transparency around budgeting and budgeting processes. And when I talked about the DLI, disbursements linked indicators, those are public, those are linked to the budget, and really putting things on budget so that we can see how money flows, but also putting in the right checks and balances and points of governance accountability for us is actually key of what we're talking about right now, whether it's at state level or below in Nigeria or across the board. So for us, it's not just about the mobilization of more financing or better use of money, but it's also the whole governance piece, and to really put weight behind governments in the driver's seats. It's really about how do you tackle good governance there, and that's one of the major focus for us in all our operations is working with the ministries of finance, not the sector only, and looking at how do you build capacity to do public financing, and indeed how you put in those carefully thought through checks and balances and monitor financial flows and expenditures.
We've got a follow-up to that from the overflow room, and the questioner asks, will disbursements be reduced if targets aren't met? And does it mean that disbursements will only be made when targets are achieved?
The disbursement will be made if targets are achieved, and actually, I think it's in the case of Mozambique, it's 6 targets, 6 of those. It's not just you achieve one, but it's a group of targets that have to be achieved in order for those disbursements to play out. Now, there are of course other sources, but this is a way to incentivize. There was a good question raised here about fragile areas and operating in difficult circumstances. We actually found that if you pay for performance, and performance is measured in terms of outcomes, not inputs, but it's more mothers accessing, quality services when they deliver. If we can shift the focus on those outcomes, even in the most difficult, fragile circumstances, we can actually increase use and quality of services and bring in private providers who are all over into the mix here. And that's, for example, how DRC in the Congo now, it's having a compact at the provincial level with various service providers around results that can really shift and make it possible to operate and actually make progress in the most fragile and difficult areas.
Great. Let's go to the back there. The lady way in the back, in the middle there. You can stand up.
Great. Thank you so much. Hi, my name is Alana Benin from PATH. I'm curious if both Grace and Dr. Merriam can talk about how USAID is aligning its programming and financing with the strategic approach outlined today, and how the GFF is approaching that with USAID together. Thank you.
We actually will let you guys answer, but we actually have a USAID person on the next panel who might be more appropriate. Okay. But I'll let you, Grace, if you want to tackle it.
I think there is some alignment at the global and country level in certain countries, but like I said, I think we have Kelly Saldana here representing USAID, so I prefer, she get a chance to address that a little later.
I won't forget you. Don't forget.
But can I compliment
go ahead.
the USAID?
Absolutely.
Since I'm not USAID. Actually, USAID has from the very beginning been a very strong partner to us, and in countries aligning their resources. Mozambique is one of our best examples, very strong U.S. mission, strong technical inputs, and so we work with the USAID both at the country level, support to DRC is one other example, Tanzania, Mozambique, but also on some of the core public health functions that we're talking about here. How USAID is helping us strengthen supply systems, and the third thing I would like to also give credit to the U.S. government, USAID, is the learning from these countries. How do you share the learning? So that's a lot of collaboration. We have regular webinars, exchanges between the 16 countries at the front line, just among them sharing best practices and then deducting, and USAID has also helped both with the learning, some core public health functions, and at the country level.
Okay, anybody up front? Yeah, go ahead.
Hi, thanks very much to the panelists. A great panel. Catherine Taylor from Management Sciences for Health. My question's to Dr. Stephen. Thanks for that great presentation on Rwanda. We know how successful Rwanda's been in reducing maternal child mortality. Can you tell us a little bit more about the implementation and scale-up of the DHIS2 dashboards in Rwanda? Because I know data's been a really important area in Rwanda for driving progress.
Thank you for that excellent question. So when we started, because these dashboards and the indicators were not in the DHIS2, we started just on an Excel sheet with the facilities, and then when they saw they were very important and helpful to them, then we worked now with the HMIS system to make sure that now there's a functionality that has been included in the DHIS2. So now it's at national level, and we've so far done trainings for all the facilities where we are working in, where they can go into the DHIS2 and generate their dashboard and look at their performance.
Great, thanks.
Okay.
Can I just follow up on
Sure,
that?
go ahead.
Actually, just this is a plug for DHIS2 symposium that's going to happen in DC in March, and Randy Wilson from MSH, who's been very involved in the DHIS2 setup and rollout, will be speaking, so there's more information available at that session.
Yeah, excellent. We have been working very closely with Randy because he was also, they've been supporting the DHIS2 and did actually the dashboards at the national level. So it was very helpful, and his team now to do at the facility level. So that would be very exciting to hear.
I think that we could all, if we offered Excel training to every health worker, we might really improve outcomes in Africa. We are right on time. You're going to have more chance to ask questions after our next panel. So let's give this panel a big round of applause. And we're going to have a couple of new people come up and have a discussion and then more questions. Dr. Koki Agarwal. She is really the chief person at JPIGO running the MCSP program, which is funded by USAID. Kelly Sedana from USAID, and Mary Taylor, who works at the Arctic University in Norway. Wow, that's exciting. As a well-known health specialist. This is going to be much more of a roundtable discussion, and I'm going to start off with a couple of general questions, and then the panel will talk among itself, and then we'll go straight to questions. Please take a look at the new players' bios because they have extensive experience. I'm going to start off asking Dr. Koki what she thinks, having been in this field for a long time, some of the critical gaps in the knowledge, the resources, and the ability of organizations to work together to achieve an end to maternal health.
Thank you, Joan. It's really exciting to be here and to be able to hear some of these wonderful discussions, and I'm really excited for this opportunity. But I think that one of the areas that we feel is a real issue is when we go into a country and do a facility assessment or do any kind of assessment that we talked about, a rapid health assessment, we recognize that many of the causes that we see as challenges that are not working are established within the health system. And the root cause of those things not working are because of the health system. And we need to be able to use that data, as many of the countries, the two country presentations that you saw highlighted the need to use that data to be able to make changes. And we don't have that data on a routine basis. So I think making sure that we have the measurement and we have the ability to use that data to make changes within the health system is important. I think, as some very wise person had said, if we go into a country and keep doing the same thing over and over again, we are not likely to get a different outcome. So we need to think differently about how we invest in our country programs and what outcomes we are interested in. And so for that, data is very critical. And I really feel very privileged that within MCSP program, we have an explicit focus on health systems to be able to use that across the board so that we are not just looking at doing the routine trainings or the routine policy development, but we are actually looking at how we can address the health systems and bring all the players together. And we'll have an opportunity. You've seen some of the work that has been done in the countries, but that is absolutely necessary to bring all the players together to address these challenges.
Lee has obviously talked about how Gates is doing that, going down to the very local level and identifying individuals. But do any of you, Mary, have any comments on how, number one, the use of data and how to somehow centralize this data so it's more effective? And secondly, how to actually work within a country to bring partners together more effectively?
So, I mean, I think in terms of data, it's most important that everybody have the capacity to actually understand and use that data at the levels at which they work. So we actually aren't only talking about centralizing it at the national level, but empowering each level to do that. And I would add the community to that list. It's not just about the service delivery side, it's about the people who use the services as well. I think in terms of building country ownership and leadership, which you've heard as a consistent theme, I think, through everyone's presentations, that what you actually also need is the partners to get behind those leaders. And it's, you know, we talk about country leadership, but it's not a glass of water, a thing, now we've got it, right? It's a process and a system and a long-term system. So that it's a matter of also the development partners looking at their own behavior and the results of that behavior over time to see what best builds and enables that leadership to move forward through generations and also to embed it in every single level of the health system. And so I guess that's actually almost a question I would pose back to the panel, is how are development partners looking at their own work from that particular sense? You know, what is your behavior, your decision making, your investments, and have those been effective, and are there better ways to actually do it? How do we improve the development partner part of that picture?
Kelly, over to you, since AID is the big player in many of these countries.
Sure. So maybe I'll answer your question first and then,
Sure.
and then go to Mary's. But I think part of your question was about what are some of the gaps in the knowledge that we had, and I want to make sure we're thinking about that as well, because it was mentioned earlier that Acting on the Call report this year identified 29 interventions that were evidence-based, but it's not that there's only 29 interventions that are evidence-based, it's that there was evidence on 29 interventions. And so there's a need to study further interventions, I think, to have a better understanding of how we can link health systems directly to the outcomes we're trying to achieve. And then within that, I think there's also a need to understand the interactions among health systems interventions. And so what we don't often study is how strengthening one part of a health system might affect another part of a health system. And I think there's both quantitative and qualitative ways that we can do that, but I think that those are sort of gaps broadly that I think would help improve our interventions within the health system space. I think to Mary's question, which is a very important one, and I think with the development community has started to look a little bit more internally at that, especially with the proliferation of data systems that are out there, and how can we move towards aligning around country systems, ensuring that we're using open source systems such as DHIS2, and making sure that if we're introducing a new system within a country, we're building that on what already exists to use the data. And then I think there's also a need on the part of the development sort of global community and donors is to accept some imprecision and poor quality in the data. I think we default to gold standard survey data or internationally recognized because we have more confidence in those results. But I also think we need to think about whether or not that creates disincentives to creating country systems, because we know that at least in the beginning, the quality may not be as good. And so how can we balance building country systems and using country systems and those data internationally with a recognition that at least at the early stages, it might be poor quality?
John, can I?
Sure, yeah, please.
I just wanted to go back to that question about bringing the partners together, and I wanted to share, I think, what Stephen had didn't highlight, but in Rwanda and in Mozambique, I think the way our program has worked and developed work plans in the country is by bringing the government, the mission, the USAID mission, and the partners together to lay out what needs to be done by this program. It's not just our team working in isolation to develop, and it's taken a little longer to develop that work plan, but bringing in that partnership, understanding what's happening across the country at the outset is a much more successful way of building a sustainable program at the country level.
Great. Lee's talked about some of the challenges and some of the, dare I say, failures in northern Nigeria on health and on this issue of maternal and child survival. Do any of you have any examples of where things haven't worked and where you've had to change it?
Where things haven't worked?
Haven't worked, yeah.
I mean, I'm sure there's examples of where things haven't worked. Sort of building on the Nigeria example, I have an example that's sort of both working and not working. So I think under the Saving Lives at Birth initiative, USAID identified the bubble CPAP as an innovation to get oxygen out to more frontline health facilities so that premature babies can get access to oxygen and work. In our work to scale that up and study its implementation, we were trying to work in Nigeria to enroll patients into a study to look at the effectiveness of the bubble CPAP. But as it turns out, the cost of supplying the oxygen is not covered under anything in Nigeria. And so in order to cover, or patients have to, or families have to pay out of pocket to cover the oxygen to put their babies on the bubble CPAP. But the cost of oxygen for a month for a child to receive that oxygen is over 130% of the monthly income of the average family. So, I mean, I think it's a good example of where a very promising evidence-based intervention to address a very high impact problem within the newborn health space runs right up into a health systems bottleneck where the financing isn't available and families are required to pay out of pocket. And so I think it requires a broader perspective to think through how can we enroll patients to figure out how to make this intervention and new technology work the way we want it to work to save lives, but also recognizing the real constraints that are there.
Go ahead, Miriam.
I think there's been a lot of learning from what didn't work, and in particular bringing things to scale, right? That and sustaining it, and I think we have a graveyard of great ideas that then never were scaled or sustained, and that's why I think we are here talking about a different way of doing business. One thing I think many in the maternal health community know hasn't worked, it is if you put a frontline community health worker out there and expect that person to be able to deliver without support from the first level facility. And it's interesting to see how countries have changed their model around primary healthcare to always make sure that there is some place within the primary healthcare facilities that can deliver quality of care. Like Ethiopia, and Mary, you know that well, how it changed from let's the frontline do it all, and we expected so much from those community workers to recognizing that you need a continuum. So I think there are adjustments being made right now to try to address what hasn't worked as well as what works. And
Go ahead.
Can I just add, I think another example in the maternal health space would be the antenatal care. While we know that antenatal care is very highly utilized in terms of the first visit, almost 90% of women may be using and going into an antenatal care, but there's a sharp drop off when it comes to 4 visits. And what happens at that antenatal care is a big black hole. We still don't know what services are being provided and how effective they are. So even though we know that there are many high impact interventions that should happen during antenatal care, how those are being provided and why they're not being provided are the health systems challenges that preclude women from using those services.
Great. What about working, well, sort of more generally, how can partners work together to overcome some of these entrenched problems within country health systems? I mean, we've talked about the corruption issue, we've talked about the data issue. Are there other ways that the partners can be more successful to get better results from these countries? Because we've also talked about the need to work within country and to go down to that local level.
I think the questions on the table, to add to what you said, is there has to be some culture change within our organizations, all of us.
So specifically?
And specifically, for example, if you
what are we talking about?
Specifically, we work very closely with the bank. The GFF is housed at the bank. And what we see in a very important change is how we work meaningfully with civil society organizations. That is not just a checklist, stakeholder consultation, check, but really engaging actively. So that is a culture change, I think, and then actually putting country leadership at the center. That is a big deal. So if we can get together around that process of prioritization with the country leadership at the table, and we all contributing to that, that is, I think, one of the greatest changes that's taking place right now.
Can I add to that? And I think part of that process needs to be the partners, and again, the locus of all of this is at a country level. It's not really sitting here in Washington or Geneva or wherever, is the groups need to be able to look at what happens and what actually happens as a consequence of what decisions they make to collaborate or to not collaborate, and to learn from that and change. And in some ways that asks these organizations to take risks. you know, that they're not used to taking. And particularly if you're a bilateral and you need to be able to report to the politicians back home, taking a risk and failing can be quite difficult. On the other hand, there are other partners who can take risks, and really being able to shift around the roles where each of your organizations can actually play the best role, I think becomes important. But the learning from it and the constant sort of self-awareness about what's happening with that and learning from failure, I think becomes very important to actually make transparent and move forward from.
Yeah, if I could, I actually wrote down something Dr. Stevens said because it summed up sort of my perspective, and that is begin with the end in mind. And I think a lot of times we have the SDGs and we sort of use that as, well, we're all working towards a common goal, but I wonder sometimes whether or not there's a common view of what that looks like on a country basis. And so I think having country governments like Rwanda articulate what they think that looks like, the achievement of the SDGs, and how their health system would be structured and organized, and then having all the donors and partners on view with that common vision, I think it then helps people work together within their strengths and weaknesses and comparative advantages, but towards a common vision of what it looks like with the end in mind.
I think, Jonah, I'd like to add to that. I think one of the issues that country governments, while they can work on a common plan if we have a strong national plan, but they also need to articulate the return on investment within their own community, within the Ministry of Finance, within the other ministries. And I think we need to provide more capacity and be able to support the ministries being able to make that case to other ministries and ministries of finance to be able to get the budget allocations and the resources behind what they want to achieve. And I don't think that we have supported ministries enough to do that.
Mm-hmm. And just one point that came up in terms of really having effective country leadership. I think we're all used to responding to directives that come from donors, be they in Washington, D.C., Geneva, or elsewhere. And I think we really need to have these honest conversations with those who are responsible for their health systems. And so I think the rubber has hit the road for us in the past with these basket funds. Because often you come to a country and you say, hey, we'll do this activity, and the health system steward says, that seems fine. But several activities we've proposed to state governments that we're interested in, and they've said, no, we're actually not going to put that on our budget. We're not going to commit to funding that after you're gone. And so we've had to come back and think and make adjustments. And so I think all of us need to have those conversations.
Mm-hmm. Yeah, I mean, obviously one of the challenges that we're facing in the United States and probably worldwide is, you know, reduction of government budgets and the need to have countries step up to the plate and, you know, domestic resource management. Those are some of the challenges. One of the questions that I have are, what are the opportunities we have right now? We know what the challenges are. What are some of the really cool opportunities we have that we should be taking advantage of in this area?
Can I begin?
Yeah, please, Toki, yes, please.
So I think that we have goals that we need to meet, and we know that MDGs were a great impetus for countries to strive towards those goals. We now have the SDGs, and we know that we have to double our efforts in order to get to those goals now. So there's a momentum that we need to build on. I think there's financing that is now being made available, even though. And also, I think most countries are moving into, you know, better economic situations so that they can actually provide a higher level of domestic resource mobilization. Another untapped resource is working with the private sector and what they bring, because in most of these countries where we work, private sector provides quite a large percentage of the services, and we need to understand that market share and be able to bring in the private sector and be able to provide services to the most marginalized as well as the other groups that are using their services. I think also using the Global Fund, which has now opportunities to invest in reproductive health or health system strengthening, there's another opportunity that we can utilize these financing mechanisms much more than before.
Yeah. I mean, Grace said it to start us off, but I think it's worth repeating. I think the fact that we're talking about health systems is a great opportunity. I think, you know, and in part, I think it's a reflection of the progress that's been made. I think we've tackled a lot of the low-hanging fruit in terms of things that we could solve with narrower interventions, and now really the only way to make continued progress and sustainable progress is to incorporate health systems into our thinking. And I think forums like this and other ones really have brought people together to recognize that. And so I think that's a great opportunity to move forward as a community and within health systems as a very linked and close part of our efforts to achieve broader goals and objectives.
Yeah, I think actually things are changing at countries also. There's much more capacity in the leadership, many more people who have been trained and through higher level education. And then you couple that with the kinds of things Stephen talked about, where the country wants to be an upper income country or a lower middle income country in a very short time period. So there's a real vision and sort of movement that can be built on outside the health sector also, I think, to carry the systems.
I also think in the economic sphere that we have a great opportunity now, the recognition that investing in humans matter for economic development. That's huge. So because that's a lot of resources, the whole, around demographic dividend, that people should be able to tap in. And in fact, and Rwanda is a good example, that understanding that investing around birth, early years, and adolescence is a very important critical point in human development. So I think we have, and there, quite an unprecedented opportunity right now in positioning health, period, but then within health, mothers, newborn, early years, adolescent, that part of the life cycle that is critical for human development. So I think that's something we should all be really smart about capitalizing on.
Great. Well, we had so many questions that I'm going to, couple of minutes early, turn it over to the floor, because I always think your guys' questions are the most interesting. So other hands shot up. Let's go right to the middle here, right there. Please stand up and get the microphone when it comes to you.
Thank you. You finally called on me. My name is Deirdre Le Pen. I'm a former scholar here at the Wilson Center, and hi, Lee. And I'm currently a consultant in public health, mainly in Africa, with a background in USAID on the staff, UNICEF, and for an oil company in Nigeria as community development officer. Now, my question I'm going to challenge you is, are we defining health systems completely? Because I heard mention of community, I've heard mention of CHW once, but I haven't heard very much talk about health promotion and the client and health demand. And it seems to me that a system is incomplete, and certainly you won't have your full statistics and full outcomes if you don't have a focus on demand. And also when you're talking about opportunities, a huge opportunity exists in many African communities today where there are trained young people without jobs who want to volunteer and help and work with their communities, and they can be an incredibly huge resource in building demand for health at the household level particularly.
Okay, Mary?
I agree completely. It's on my cards here also. And I guess the question is how do we shift health system strengthening and how we think about it and what we do about it to really be driven by community and patient-centeredness, whether you want to talk at the community or the individual level, and to go beyond the sort of words like users, because it's really participants. We co-produce health now, and as health problems shift away from some of the more acute infectious issues, and we need to get into heart disease and diabetes and other sorts of things, you need even more engagement with patients, because what they do or with what communities do is what's really going to result in the outcomes. And I think also if you put an equity lens on this, really trying to understand those communities that haven't been engaged and reached, it's not going to happen just through a top-down driven system. I think has been learning about that. So if you look at the success factors studies and so forth from the MDGs, you find that countries that invested in community platforms and really trying to get to that front line to most of their people had the most success. And so there is success to build on, but it is, I think, a paradigm shift to ask people to think about how the patients will drive the development of the system. And I guess one of the places actually that could be started with is looking at data and how we really understand how they contribute to that data and how they, you know, what's actually happening at that engagement level that can be built over time.
Yeah, I mean, I would absolutely agree. Communities are important to health systems, as is behavior at all levels of the health system. So not just the user behavior, but the provider behavior, the manager behavior. I would push back a little bit because I think too often in health systems we fall into this definition trap, which I think just gets us like arguing about the definition of health systems. You know, is it 6 building blocks? Do you add the other ones? Where is it? And I think that it's not necessarily a productive discussion. And I think, you know, you get into debates about, well, you know, what counts as health system strengthening versus doesn't count as health system strengthening. And so again, I think if we can all go back to begin with the end in mind, where are we trying to go with health systems, and how do we take all of the resources we have, all of the knowledge we have in the community field, in behavior, across economics and financing and clinical care, and bring all of that together to move towards the outcomes we're trying to achieve.
Can I just add, I think within MCSP, we've never considered the community as not part of the health system. We include the community as an essential part of the health system, even though the WHO building blocks might not mention it as one specific building block. And also, I think we worked with the community in terms of engagement to be more empowered and be more representative of the behaviors and the needs of the individual. Also to look at formative assessment as to what is the need of the, you know, what do people really want. And then also use the community to deliver services and also to be a mechanism for holding the government and the facilities accountable. So there's many different ways that we've worked with the community and used it as an essential part of the health system.
Go ahead, Miriam.
Just to pick up on the demand and supply question, there are some countries, the front runners in the GFF, who really discovered the huge gains they could make by just bringing that together. They had bilaterals working one part of the country on demand generation, others in the other part of the country on supplies. And just Cameroon is a very good example of that, where you had, you know, French and Germans working to support demand generation in one part, and the bank and others on supply, and just bringing that together, what huge gains could be made. So, and how we define demand, it's not just about users and providers, but it is really about community actors. I think linking back to the very first question on professional associations, just professionalizing the frontline workers, imagine how much we can create in terms of jobs, especially for girls and adolescents. So I think what's really nice about thinking really creatively around that integrated community platform and thinking broader about this is the job creation, which is really alarming now for young people. So professionalizing a lot what's happening around volunteers is a huge step forward in the right direction, looking at broader development.
I actually had a follow-up for Mary. We had a question about community data. How do you get actual data from local levels? Does anyone have an answer how you get good data from a local community at that level? And I thought you might have the answer.
So I think it's been done, but it's small scale.
Mm-hmm.
I mean, so there are many examples.
Okay.
But it tends to be in smaller projects or research projects, those kinds of things. I don't know of a countrywide system that really does that. So I think it's the problem of scale.
Well, I think it's also the same problem we have with data at all levels of the system, which is that the people who are producing the data need to own and use the data in order to make sure that it's valuable and continues. And so it's not about how do we get data from communities, but how do we get communities to use data to track community level involvement or community strengths or community problems, and then to communicate that data. And again, I think that is true at all levels of the health system.
We have, I think, examples from Rwanda and Tanzania where they've used community scorecards, and you know, if people are interested, they can talk to Stephen to find out more.
Okay, I have a question from the outlying room from Stephanie Bowen. She wants to know, she says that women's voices are obviously key to accountability and strengthening the health systems, and what is being done to make sure that women are playing a role in the health systems? Take it away. Since we're all women except for Lee. Maybe we'll give it to Lee. Lee, go for it.
I should probably not jump in and answer that, but I mean, it is absolutely an important time for this, and I will just say within my own organization, there's been increasing recognition of this, and as Melinda has really found her voice on this issue, there really is a lot of efforts that we're making to try and ensure that all of our investments recognize and integrate empowerment and quality approaches. So stay tuned from us. We're hoping to continue to support that more, but I'd love to hear from the woman on the panel.
Actually, Ethiopia is a good example of this, you know, where the community health worker program or platform that they put in place is mostly women, and women that came from villages, and that's a very powerful platform. They speak, they provide input into the system. They're at all of the meetings with various levels of the health system to do new plans and so forth. And they've even extended it now to have what they call a health development army, a women's development army, which are essentially community volunteers. It isn't as strong a network, but the idea was to engage women in their own health from the beginning.
And I think given that women are the primary users, especially in the reproductive, maternal, and child health space, listening to their experiences with the health system and making sure that the health system is providing care in a way that's respectful to them, that upholds their dignity, and understanding that and responding to that and sort of valuing them as the primary clients of the system is key to making sure that their involvement is heard.
I mean, one of the points that's been made here is that the lessons learned need to be translated to other countries. So how do you translate the Ethiopia model to Mali, for example, or?
So Ethiopia's been doing that. I don't think we translate it.
Oh, yeah.
You know, I think they translate it.
Right,
And but they have made an effort to do that, where other countries have asked to come in and observe their program, and they come on learning visits, and they've asked Ethiopians to go back in and consult or at least advise them on setting up their own kinds of programs. So I think the more exchange that happens like that, the more valuable that translation actually is, because they can discuss the practical issues. And we talk about health system strengthening, right? But that's really where the learning about how to set that up and what to do and what not to do really comes from.
And I think if we engage the community and the women in the process of developing national plans, strategies, women are not afraid to speak out. And if you engage them, they will speak out. So I think we just need to provide a expanding platform where we can engage women. I also think investing in the midwife, which is the frontline health worker, in many ways have empowered women to become champions of change themselves, because these are essential health workers who can now change and transform communities that they work in. And we saw really great evidence of this in Afghanistan, where we had worked to train many midwives, and they became the champions for change at the local level.
Great. Okay, let's go to the back. Let's go to this side. How about way in the middle right here? The man in the middle.
Well, thank you very much. My name is Akbayong Ekanem. I work with Apps Associates. My question is actually for Lee and then Dr. Miriam Cleason. One of the projects I work in Nigeria is the Health Finance and Governance Project, and one of the key levers that we have realized we've been able to push has been the legislature, especially in boosting domestic resource mobilization for health, and more broadly, getting the claim and the push for universal health coverage, one of those things that get passed in the bills, and they become champions for these discussions at those high levels. Any of your experiences to this type of efforts, especially in Mozambique and maybe in the other states in Nigeria where you've worked in Lee?
Thank you very much. what I'm first going to say is what I should have said about the women's voices question, I think.
Uh-oh.
So there are two things that really are impressive and exciting for me right now. And one is the experience that in India of women's self-help groups that not only lead to empowerment, but significant reductions through well-researched trials in neonatal mortality. And the second is new work that we've been able to support on group antenatal care. We've jumped on that bandwagon to generate some evidence for that, and really empowering women to participate in their own care has led to significant outcomes, at least from early results, and we'll work on that further. In response to your question, yes, so working in a democracy, I think we do need to work with legislatures, we need to work with civil societies, and there are a number of instances where we have worked through information with both state and federal legislatures in Nigeria around the National Health Act and around specific acts that have enabled health financing and other areas. So I think the support through groups like Mama Ye, scorecards, both for budget, for putting things on budget and budget disbursement are an essential complement to what goes on within the health system. So that's great work.
Just to echo what Leah said, we use actually Nigeria as a very good example of where a strong CSO voice, right, empowered with a great scorecard with clarity on what are the results to expect from your state level authorities, but also putting pressure at the national level around the legislation, around scaling up a basic package of services and what it contains, is a great example of very active civil society groups who have come together around a very important agenda. So there's a lot to learn from that, and in particular, I think a great scorecard where they're actually looking: is financing going into immunization? Is financing going into mothers getting quality of care, and trying to actually keep a pressure on that. So I'm glad you raised that.
Okay. Yeah, right there. Go ahead.
Hi, my name is Dominique. I'm a senior at the George Washington University. So thank you so much for holding this panel discussion. It's been really great. Going off of a point that Dr. Stephen made earlier about contextualizing policy within a certain country to make sure that it works or doesn't work based on cultural and community values, and also something that Lee said earlier of really looking at key community players. Who do you hire or talk to find those community players and the key people who would really kind of empower the community within itself and also prolong the change after, for example, USAID is gone or our influence is gone? Thank you.
Yeah, that's a great question. Yeah. In other words, there's no Glassdoor or Monster.com to find out, really good hires. Yep. So, Lee, do you want to answer that? Start with that?
I'm not qualified to answer that, but what I will say is there are countries where there have been really, and regions where I've seen really amazing efforts towards pro-poor work and empowering people fundamentally in Latin America and the Caribbean and also in South Asia. And so I think if we can build those indigenous efforts to empower people and identify which are those groups, then we can hopefully support that.
And we think this is so important that these become also country decisions, right? Because at the country level, who are the best knowledgeable local NGOs, which are international NGOs are really relevant for what we are trying to do. We think that should also be shifted. So in the GFF, unlike other global financing mechanisms, we don't pay, for other groups to provide that technical input, but we want to channel financing through the government to contract in and use the services of local NGOs. In particular, when we talk about civil society and voices, how do we ensure that we get the right voices at the subnational level, and how do we empower and build capacity there?
Yeah, if I could just add, I think that the question itself is a very good example of the importance of doing the work on the ground in the communities where we are. And I think there's only so much we can do at a global level. We can sort of have these conversations, raise the profile, identify evidence, and that sort of thing. But when you really get down to doing the work, you need the people on the ground. Because if you go into a community and start asking questions, people know who the leaders are. And I think similarly, even at the government level, within the country, people know who sort sort of shining stars are and who are people that are willing to do work and think new ways. But you have to be on the ground to have that knowledge.
Right. The lady right here in the front, please.
Thank you. I'm Alessandra Resu. I work for Humanity and Inclusion. Some of you may be familiar with the name Handicap International. Humanity and Inclusion is the new name, rebranded a month ago. I wanted to ask, we have heard a lot about how this project and these initiatives are willing to reach those who are underserved. How these initiatives are aiming or checking that the underserved, who are people with disabilities and specifically women and girls, are really reached by these initiatives, and how in cases this is still represent a challenge, as we know it is, organizations like Humanity and Inclusion can support this kind of initiatives. Thank you.
Go ahead, Koki.
I think, this is a very important question, and many times we are so involved in just looking at the coverage that we forget to look at the targeted groups that we need to reach the services who are not reaching. And even at a country level, if you just look at the data at an aggregate level, you may not see those challenges. But when you dig deep, and we have to start digging deep, because otherwise we will not make the difference we want unless we reach those women with the highest burden or the children with the highest burden and address their needs. So I think just going back to the first point we raised, I think looking at using data to understand that and making sure that it is something that we report on, that are we reaching those who are most in need.
Let's take a question in the back here.
Thank you. My name is Mona Bormett from Christian Connections for International Health. And I was just curious, I'm a big supporter, of course, of strengthening public health systems. I've heard a lot about ministries of health. And just curious how you all work with strengthening private health systems. Many of them may have MOUs with the ministries of health, but what we find with supply chains and other issues is that Ministry of Health and public facilities are served first before private facilities. So just curious. Thank you.
Mary, do you want to tackle that?
Probably not the best one.
Okay.
For that one.
Anybody have who knows about private systems, which in Nigeria, by the way, are quite very prominent and very prevalent right now?
We agree with you that you can harness the private sector in so many ways. We've talked a bit about private providers, and when we talk about DRC, when they talk about MOU and their compact, it's public or private, but that's private providers. In core public health functions, the private sector has a lot to learn, for example, from Senegal, around how do you reach the last mile with good supply systems. So I think there is a lot of that we can harness, not just around providers, but also core public health functions from the private sector. And that is what we are trying to do in the GFF, and also take that across countries. Especially, I wanted to flag the Senegal experience, which I'm sure several here, including the foundation and others, were involved in, and where the government has said, okay, that's great. We did set a good system for family planning. How do we expand that across basic services, and how do we make it nationwide? And that's where I think the comparative advantage, for example, of the financing facility that I represent comes in.
Yeah, I mean, I would just say, I think working with the private sector is something we can do a better job of across the board. We know the private sector is an increasing provider of health services in most of the countries we work in. One intriguing idea is, our colleagues in family planning have for a long time looked at, with respect to family planning commodities, the total market approach, and how are we ensuring that commodities are available at every different point of service delivery, and that the market is both segmented to the appropriate people, but then also cohesive so that everyone has access. And I think taking a concept like that and applying it to services more in general could really be beneficial, so that we're recognizing the role that the private sector is playing, who they're targeting, who they're reaching, and that's part of an overall strategy and prioritization within the health system.
I think that's a really important role for the government to play in terms of the stewardship function, and how to make sure that they include the private sector when they think of the total market. And many times we just work with the Ministry of Health and they think of their facilities, but they really need to think broader. And again, they will not reach their goals unless they consider the private sector as an essential complement to what they're trying to achieve. And there are many different approaches that have been used to improve the quality within the private sector, engage, build a public-private partnership, but we definitely need to do more.
That's a great final statement, which is we came here saying public-private partnership, and we end saying more public-private partnership. We're going to end our questions there, but Dr. Grace Chi is going to wrap up the session for us, and so we welcome her up here to kind of make some final comments and to wrap up this really, really interesting discussion. Could have gone on all day, actually.
Thank you so much, and thank you to all of our panelists for a great discussion and to all of the great questions that were raised. I didn't prepare any closing remarks, but I wanted to use a couple quotes that came out in the middle of this discussion just to sort of sum up some of the discussion and the goals for this session. So please excuse me if I've misquoted you. So just to start, I just want to say that one of our panelists said that vertical programs can't sustain their achievements over the long term. We need to put countries in the driver's seat and make sure that we align behind them. We need to identify the states and individuals who can facilitate change, and then we need to support them. And then let me end with, these are very brief remarks, that we've tackled the low-hanging fruit, the progress that we've made so far. The only way to make sustainable progress in the future is to make improvement and incorporate health system strengthening into our programming. So I hope that we all, come away convinced that that's the path forward. And thank you all for coming.
Thank you. So that concludes our program at 11 period with 17 seconds. So anyway, thank you all for coming.